Right. Good morning, everyone. I am Kavitha Karnik. I am the program director for the Child Neurology Residency Program, and it's my pleasure to introduce Dr. Luca Farrugia as our speaker this morning. Dr. Farrugia completed his undergraduate studies at Boston College and went on to earn a Master of Science at Boston University. He then completed medical school at Mayo Clinic Alex School of Medicine here in Arizona and is currently a PGY4 in our residency program. He is looking forward to pursuing a fellowship in epilepsy here at Phoenix Children's following residency graduation. And Dr. Farrugia, we all look forward to your talk this morning on the recognition and management of metabolic epilepsies.
All right. Well, hi, everybody. Um, Thanks for that introduction, Dr. Karnik. Yeah, like I said, PGY4 here in the Child Neurology program. I'll be talking a little bit about a couple specific, metabolic related epilepsies. There's a long list of, seizure disorders related to metabolic disorders, but I wanted to talk about couple that were specific that one have sort of specific non-seizure medication related treatments, and that for the most part are not on our newborn screen. So my objectives for today, identify, talk about key features that should raise someone's suspicion for a metabolic etiology of epilepsy. Two, about talk about what would be a practical diagnostic approach to these disorders. And then three, describe sort of management strategies that are sort of specific for these disorders, and specifically in these cases that are not necessarily our classic seizure medications, but more metabolically aimed. And so the ones I'll specifically be talking about today are pyruvate dehydrogenase complex deficiency and GLUT1 deficiency, both of those sort of paired in the fact that they have the sort of same mainstay modality of treatment. And then also pyridoxine-dependent epilepsy, pyridoxamine 5-phosphate deficiency, bioxidase deficiency, and molybdenum cofactor deficiency, with those four kind of being linked in regards to sort of typically intractable neonatal seizures and sort of working through the steps of those. And so we'll have sort of a flow chart at the end to kind of walk through kind of step by step way to sort of think about treatment and workup for that specific situation, especially before you have like a diagnostic confirmation. So I'm going to start with pyruvate dehydrogenase complex deficiency. So this is a specifically disorder of carbohydrate metabolism caused by a deficiency in sort of one of the three enzymes or main parts that make the pyruvate dehydrogenase complex. And so specifically, that is sort of impairing our ability to convert pyruvate to acetyl-CoA. Um, which kind of redirects our pathway of making ATP. And so if we can't go down that pathway into the Krebs cycle, which I'm sure we all remember every step of, then we sort of get funneled over to lactate and sort of and sort of and make having lactic acidosis from an elevated lactate. So it's specifically the main subtype of PDCD is in the PDHA1 gene. And it's X-linked recessive, but there's also a couple other subtypes that are autoimmune recessive, and sort of like I said, all of which combine to form one of the three parts of that specific enzyme. So it can, and this will be a common theme with everything that I talk about today. They can have a pretty variable presentation, having a pretty wide spectrum of clinical presentation. And so at one end, you can see it relatively quickly present after birth in a neonate that's significantly hypotonic, that's lethargic, it's not feeding well, yeah, that's tachypnic. But then you can also see it progress. In later in, the first year of life or even longer than that until its first presentation with developmental delays, seizures, ataxia, recurrent respiratory illnesses, movement disorders. Um, all of the sort of ones I'm talking about today have the potential to present for the first time as a seizure, and that might be your first sign that something could potentially be different. And so that's specifically why I wanted to talk about some of these today. As also, there's going to be common with all of these um, metabolic related epilepsies, sort of fasting, illness, even exercise can worsen symptoms. Pretty much, there's a lot of seizure subtypes that have been described. Generalized tonic-clonic seizures, tonic seizures, myoclonic seizures, you have spasms. They've seen pretty much all types of seizures. Median age of diagnosis is about 1 year of age, and sort of the prognosis that about 60% survive past 3 months, and 10% past 4 years of age. So the workup, initially would be sort of your basic labs, which will clue you in that this patient might be acidotic, and including getting a lactate to show that that is elevated. It's important when you're thinking about PCD, um, to look at the lactate in comparison with the pyruvate because the ratio should actually be relatively normal. If we go back to our graph, both the pyruvate and the lactate should be normal based on where our sort of problem in the chain of command is. So that would be different in some other disorders that might have an elevated lactate, but a normal pyruvate, and so that can help in part differentiate because of um, part of the byproduct. We also have an elevated plasma and urine alanine. And then specifically looking at some of the cells, you'd see a low PDC enzyme activity in cultured fibroblasts. Some imaging findings that can be different. It's not slam dunk every time, but some sort of specific things I've seen have been cerebral atrophy, asymmetric ventriculomegaly, and then also sort of more midline defects, corpus callosum, agenesis, and dysgenesis. And then confirmatory diagnosis would be looking at some of the genes that I had mentioned. For example, these genes are, especially the main one, are on some of the bigger panels, like the neurodevelopmental disorders panel that Invitae has, as well as the comprehensive neurometabolic disorders panel. And so, one of the reasons why I'm talking about this is that the management, including for a lot of times for the seizures, can be just the ketogenic diet. Um, way this works, is we're sort of finding a different way to get to acetyl-CoA on the pathway. So instead of going from pyruvate, we're going from sort of the fatty oxidation pathway. Um, and using, just this and sort of correcting the sort of error in our metabolic pathways demonstrated significant seizure control, including even seizure freedom, a significant improvement in developmental delays and movement disorders that are seen with these patients. And as is going to be the case with all of these disorders, the earlier that intervention is started, the significantly better outcome is reported. A lot of these patients also get thiamine supplementation. And there was actually a trial in Ohio of adding this to the newborn screen. It's quite rare. So there were a couple cases that they caught, but it is not on the um, on a newborn screen, pretty much anywhere, including in Arizona. The next syndrome I wanted to talk about was GLUT1 deficiency syndrome, glucose transporter type 1 deficiency syndrome. So in this case, the problem is with the transport of a glucose into the brain, into the CNS, because we have abnormal GLUT1 transmitters due to mutations in a specific gene I'll talk about. And so on a, despite a normal serum glucose, we have a sort of abnormally low glucose in the CNS. And, um, and it's specifically primarily expressed on the endothelial cells of the blood-brain barrier and in astrocytes. And so this is especially problematic in our early age because it's a problem in areas of rapid growth, in high metabolic demand, which is obviously infancy and early childhood. And so, sort of crudely put, this low sort of energy state is disrupting the membrane potential and neurotransmitter cycling, which in turn leads to seizures, which in turn leads to impaired synaptogenesis, myelination, neurotransmitter synthesis, which is, leading to global delays and global slowing in function. So from a genetic standpoint, the primary pathogenic variant is the SLC2A1 gene coding for the GLUT1 transporter. There actually can be, with sort of single transpositions, there can be mild to moderate symptoms, whereas opposed a whole deletion of the gene will lead to more severe symptoms. It's autosomally dominantly inherited, and 90% of the time de novo, 10% inherited. This is also on the neurodevelopmental panels that I talked about, but as well as the epilepsy panels, including the one that Phoenix Children's offers as well. So there's a couple interesting parts of the presentations, similar like I talked before. It can be pretty variable, so it doesn't have to include all of these things, but something that's commonly seen and can sometimes be the first sign is these paroxysmal head-eye movements, which are sort of characterized by repeated saccadic conjugate movements of the eyes that are accompanied with head movements in the same direction. They're interesting to look at. There's a couple YouTube videos. I didn't dare try and import them into my PowerPoint because I know that it typically does not go great trying to put videos into these things. But it'd be interesting if you are interested to go take a look at. Seizures are also common and sometimes the most common presenting symptom. Commonly prior to 6 months and commonly refractory to seizure medications. Similarly, we can see multiple different seizure subtypes, myoclonic seizures, atonic seizures, GTCs, atypical absence seizures, especially at this, early age, atypical to see absence seizures at this age. Another thing that can sort of clue you in that maybe this is different than sort of some of your more run-of-the-mill genetic epilepsies. Seizure frequency tends to decrease in age regardless, and many times resolves by adulthood. Other things you can see is deceleration of head growth, developmental delays, and movement disorders, especially in the older population, older children, adolescents, where you can see ataxia, dystonia, tremor, chorea in a lot of these older patients. And similarly, a lot of these symptoms will be worse in fasting states, in stress states, and in illness. Workup, EEG is not needed for the diagnosis, but In some cases, it can be helpful, especially when you're dealing with sort of a younger patient and you're not sure if the movements are epileptic or not. We had a patient on service earlier in the year um, who um, had some sort of amor kind of staring like spells with some facial twitching that parents were having a hard time describing, and so we weren't even sure at that time, or seizures. So once we captured those on the EEG, improved them, and then given the clinical picture, that actually pushed us to be able to kind of proceed with this workup. And really, besides genetic confirmation, one of the key findings for diagnosis for this is comparing the CSF glucose to the serum glucose. And so, and these in GLUT1 deficiency syndrome, you have hypoglycemia, which is sort of low glucose in the CSF compared to the serum. So you want to get a serum glucose around the same time you're getting your tap, and ratios of less than zero point 0.5 would be abnormal. It's been sort of investigated and it seems like, there is definitely seems like more of the severe subtypes of this disorder have lower glucose as would be expected, so less than 40 in the CSF, as well as a ratio of less than zero point 0.4 has been associated with more of the severe subtypes of disorder. And then, like I talked about, as part of the workup, getting the genetic studies as well can help you with um, confirming this, although obviously it will take some time. So you can get the lumbar puncture quicker, which then will help you get the treatment process going more quickly, which in the same way as our first disorder is the ketogenic diet is a gold standard for treatment of GLUT1 deficiency syndrome. In a similar way, or sort of using ketones to sort of bypass where our error in the system is. So in this case, our problem is with getting glucose um, into the brain, and so we can bypass that by using ketones, that which then can be used to acetyl-CoA and then be go through our typical processes of creating ATP. Similarly to our other disorders, the earlier the initiation of the diet, the better the developmental outcomes are, the better chances of obtaining seizure control. But it has a good rate of control with the diet, with a good percentage of our of patients achieving seizure freedom with the diet itself. Okay, and now I want to kind of move more into some of the ones that especially we can see with intractable epilepsy, especially in the um, neonatal period. So first, I have pyridoxine-dependent epilepsy, and the first one I'll be talking about specifically the ALDH7A1 variant of this, the more common one, which is a disorder specifically in the lysine degradation pathway that's leading to early onset intractable seizures. And so this is not specifically pyridoxine deficiency, but more that these patients are metabolically dependent on pyridoxine, so therefore requiring excess um, supplementation. And in the more common type, there's a mutation in the antiquintin enzyme that's coded by ALDH7A1, which leads to excess AASA, and as well as P6C. And the axis activity, especially the ASA, can lead to reduced enzyme activity in the CNS that sort of regulate transmission of signals between neurons, as well as brain development that can lead to some of the problems that some of these patients have. And so clinically, you can see seizures quite soon after birth in a majority of these patients. And one of the more telltale signs is that they're not really responsive to the traditional seizure medications that we use. And you can see multiple different subtypes of seizures, focal seizures, tonic seizures, generalized seizures, as well as spasms. And there's some suspicion that some of these patients may even be seizing in utero. With mom, and that maybe their parents, mom is feeling some sort of abnormal movements, that actually might be seizures. And a lot of times these frequently cluster and become prolonged and progress in the neonatal period into status epilepticus. Other sort of signs that you can see in these patients are fluctuations of tone, irritability, poor feeding, lethargy, like we talked about, and then more further along, intellectual disability and developmental delay, in addition to the seizures. From a workup standpoint, there's some labs and some tests that you can do, but realistically, from a timing perspective, uh, the sort of workup is if you're suspicious of this, if the patient kind of is giving a metabolic picture and we're having a hard time controlling their seizures, at close to birth, that really the workup is trying pyridoxine supplementation and seeing if there's a clinical EEG improvement once starting it. You can look at some labs, like you can look at elevated plasma and urinary levels of AASA, and then obviously there's genetic. You can send up panels like the epilepsy panel that we have here in Invitae, or the treatable neurometabolic disorder panels, but obviously those will take some time to confirm. So realistically, this is a situation where part of the workup is trying the treatment. And so, like I said, the management is pyridoxine supplementation. In newborns, you're going at about 100 mgs a day, and then infants could have maxing out 300, children and adolescents maxing out at about 500. Also part of the management is um, reducing lysine intake in the diet, as well as arginine supplementation. So triple therapy for this disease is considered all three of these. So pyridoxine supplementation, arginine supplementation, and then lysine restriction in the diet. Um, you know, early supplementation can be associated with seizure freedom in a lot of these patients, although kind of regardless, a lot of these patients end up having some developmental and intellectual delays despite treatment. I want to kind of pair that with pyridoxamine 5-phosphate deficiency, which is a similar clinical picture to um, pyridoxine-dependent epilepsy. So also with seizures soon after birth, also with multiple seizure um, types. It's also, refractory to seizure medications and also frequently progress to status. But the difference is that it's a different mutation in the pyridoxamine 5-phosphate oxidase. Um, and therefore, these patients are less responsive to pyridoxine. So can look very similar to these patients, but then you're trying pyridoxine and you're not seeing success. And so in this case, the management is actually slightly different. It's trying pyridoxal 5-phosphate, PLP, the active form of pyridoxine. And these patients should be more responsive to that. And so similarly, the workup is confirmatory workup is um, genetic, but in the meantime, it's sort of trying the treatment if this is sort of your suspicion, but then you're noticing that they didn't fully respond or didn't necessarily respond to the pyridoxine. Um, but biotinidase deficiency is the one I included here. Um, that is actually on the newborn screen, but it's sort of part of like sort of well laid out pathway that I found. So I wanted to talk about it here anyway. So it's specifically a metabolic disorder preventing the body from recycling biotin, vitamin B7, and so a mutation in biotinidase leads to a depletion in biotin. And so, as the part of the process of biotin being sort of used for amino acid catabolism, fatty acid synthesis, and gluconeogenesis, it sort of goes through a loop. And part of that it is biotinidase converts biotin um, back into sort of the free biotin pool. And so obviously a deficiency in that is going to sort of run your levels of biotin out if you're not recycling it. Similarly, there's a sort of spectrum in these cases, and you sort of can be characterized in sort of the profound BTD or partial BTD. And profound would be less than 10% of normal activity of biotinidase. Clinical features for these, similarly, neonatal slash infantile seizures, similarly, multiple different types have been seen, but also some characteristic non-seizure related findings, including alopecia, rash, especially around the mouth and the eyes, brittle nails, conjunctivitis, and then eventually um, developmental delays. The workup, as far as we have now, is that it's part of the newborn screen in the US. But if there's concern that patient was either born outside of the country or something went wrong with their newborn screen, then you can do a botanase enzyme activity assay and then obviously genetic, specifically sequencing the botanase gene for any variants. But it's I have a screenshot of our newborn screening panel, and it's number 29 on there. And even just looking at the newborn screen, we can see some other disorders, even some other metabolic disorders here that are associated with seizures that I won't be talking about today, but I think I wanted to specifically talk about, for the most part, ones that aren't on the screen, and that can have very specific metabolic treatments. But there's a lot more that we could talk about in regards to metabolism and seizures. Um, I'm sure we could do a couple talks about them. And so management is lifelong biotin supplementation, starting at 5 to 10 mg per day. Um, Interestingly, these patients should avoid ingestion of raw eggs, as the protein in them, avidin, can bind to biotin and sort of decrease its bioavailability, which would be obviously working against their interest in these cases. Um, Apparently, cooking the eggs deactivates this and is not as much of a concern. Untreated, these patients can be symptomatic early on, very early on, but on average, 3 to 4 months, seeing, and those untreated patients will typically develop seizures, like we talked about, but can also develop sensorineural hearing loss, optic atrophy, as well as some of the other clinical symptoms that I had talked about before. But these patients can have a very normal life and lifespan if treated early, as long as we're sort of filling that need that um, the that we're not getting with our cycle, that they can have a relatively normal life. Okay. And then the last one that I wanted to talk about today was the molybdenum cofactor deficiency, MOCD. And this is specifically a defect in the synthesis pathway of the MoCo cofactor, starting from GTP. Um, And sort of it's characterized into three types, and sort of just depending on where along the way the error is. But the end result is sort of causing loss of sulfite oxidase, xanthine dehydrogenase, and aldehyde oxide activities, which will lead to a toxic sulfite accumulation. And so in the chart there, you can sort of see how it's broken down based on where you are into the three types. Um, So type A at the top with the MOCS1, which is a majority of the cases sort of stops at the very beginning, where CPMP is not formed. Whereas type B with MOCS2 and 3 um, is sort of the middle point, and then type 3 with the GPHN gene at the sort of last stage of the pathway. And so all three of these subtypes are clinically indistinguishable, but at least the first type subtype has a little bit different management strategy. And so for in these cases, in the sort of severe cases, like all of these ones that other ones that I've previously described, there's a pretty wide spectrum, but you can see really early onset seizures, hypotonia, opisthotonus, poor feeding, and respiratory compromise all in the first few days of life. Whereas you can, in the late onset versions, then you'll typically have milder symptoms that are more typically exacerbated by illness or insult, and where you can see mental status changes, dystonia, movement disorders like chorea, ataxia, and nystagmus, as well as fluctuating tone. Um, and like I said, all three of those subtypes that we talked about, A, B, and C, are um, indistinguishable. So the genetics will help you parse through them. As part of the workup, you can do urine dipstick for sulfite levels, which should be elevated in these cases. Obviously, you confirm genetics, and their MRIs can have a characteristic pattern with diffusion restriction and T2 hyperintensities sort of throughout the cortical ribbon, subcortical white matter, including in the basal ganglia and the brainstem, as well as some gyral swelling in some of these patients. And so for specifically type A, there's a medication, Nulibry, it's fosdenopterin, which early on is a daily infusion, and it's sort of replacing what you're missing from that first step. So it's a CPMP substrate replacement. But then a cysteine restricted diet is part of the mainstay of treatment, which is sort of decreasing our downstream sulfite production, which is our main issue in this disorder. And so, I found on UpToDate, I think I found a pretty useful chart that kind of walks through uh, a sort of reasonable approach to managing patients that you're, suspicious, especially of these last four disorders that I talked about. And so specifically, you'd start with, okay, we have a neonate that's seizing and does not seem to be really responsive to a lot of the medications that we gave. And then maybe there's some other clues based on how they're looking and behaving that, this could be a metabolic origin of their seizure disorder. And so based on, you know, kind of playing the odds, a good first step would be, like we had talked about before, just trying um, paradoxine for 3 to 5 days, and then assessing for um, a response or not. And so, if yes, then that kind of would um, favor a anthraquinone deficiency or or ALD 7A1 pyridoxine deficient epilepsy. And so then you specifically test for that, and that can be confirmatory. And then if your genetic testing is negative, or if you don't have an adequate response to the pyridoxine trial, then you can move over to PLP. Um, Now thinking more, maybe is this PMPO deficiency. Um, and so similarly, if you do have a response, then that you would seek genetic confirmation that way. If you don't, then it considers the next step, leucovorin. Um, these first the PDE at least used to be called like a folinic acid responsive epilepsy, and so that is also part of the management is seeing if they are responsive to leucovorin. If no, then you're starting to move sort of further down. Then, your tree moves to, did this patient get a newborn screen? Have we already excluded biotinase deficiency? If no, then trialing biotin and similarly assessing for response. And if there is a response, then you can confirm with, biotinase activity in the serum, or genetic confirmation. And then if no, can move towards getting a urine dipstick for sulfite levels, and if elevated, then that would appear more consistent with a molybdenum cofactor deficiency, which, like we talked about, you can confirm with genetic testing. And then if that's normal as well, then I think you have to be a lot more broad in your workup, and sort of maybe more broader genetic testing and looking at inbred errors of metastasis and channelopathies. Um, if they're not responding to sort of this first step-by-step trial. So kind of from a sort of summary standpoint, like the, thing that I think I got from this and I wanted to convey is that like alarms should start going off, especially if we're having neonates and infants that are having seizures that A are either atypical for their age or that are refractory to typical ASMs, especially if they're going into the status and we're having a hard time controlling their seizures without really any known clear insult or cause like infection or bleed or something like that. Um, that maybe should start, and especially if, they're having some other things that might key us in that this maybe is potentially metabolic, like they're, in addition to their seizures, they're lethargic, they're not feeding well. There's sort of some fluctuation that seems in regards to illness or the patient's development delayed that might start making me think that, um, it maybe might be worth more looking at the metabolic route. And then obviously, in addition to what I talked about, there's many other disorders that are on our newborn screen. But obviously, if we have patients that are presenting like this and are internationally born, that they had a lot less substantial or maybe without a newborn screen would be um, worth specifically looking into a lot of these more metabolic epilepsies. Something I just wanted to highlight that I think is important for families, especially with some of these more rare disorders that, especially their other doctors may not be as familiar with, is kind of how important community can be for these patients in regards to them making themselves aware, in regards to research, in regards to sort of a community. I think it can be really helpful to connect families to sort of these resources. GLUT1 has there's a GLUT1 Deficiency Foundation, which has a great website and a lot of really good resources for families for connecting people. Um, p PDCD also similarly has a research for a cure page, which also has a lot of really great information. Is also really keyed in on research and you know enroll in getting families aware, of studies that they potentially could be enrolled in. And then when you get even more rare, where they don't usually have dedicated websites, at least the National Organization for Rare Disorders can be helpful for a lot of these families, but both from an informational standpoint, as well as a community standpoint. Um, and that is what I had for today. So happy to uh, talk if we have any questions.
It
Hey,
looks like
Luca, great job, Angus here. Um, Really a challenging topic and diagnoses that are so critically important to make as soon as possible. And I think you summed it up really well when you said that if a child has atypical presentation or the seizures haven't stopped, you need to definitely explore, why and understand why the child is having seizures or developmental delays or particularly developmental regressions. Fortunately, we have the ability to order genetic testing now, which is standard practice for really virtually all epilepsies. Um, Even structural epilepsies can often be associated with identified genes and with or without associated metabolic problems. So um, really nice overview. One of the challenges is just the variable presentation of some of these conditions. Like, for example, GLUT1 may present in infancy with seizures, but may not present until adulthood with a movement disorder,
Hmm.
and they should never have seizures. So it remains a challenge to sort out the phenotype once you've identified, and then figure out identify the genotype that goes along with it.
Yeah,
Great job, Luca. It was an excellent presentation.
thanks. Well, I'm definitely more than happy. Oh, go ahead.
Uh, I would like to build off of what Dr. Wolfong just said. So many of these metabolic conditions have such variable phenotypes and presentations. Um, I would argue that you don't have like a specific metabolic phenotype that raises concern for a metabolic disorder.
Mm,
There are various different phenotypes that can maybe raise concern for specific metabolic conditions, but there's so many metabolic conditions that can lead
yeah.
to seizures, and you've only touched on a very, very small slice of
Hmm.
them. Um, and I think it's important to consider that more targeted differential rather than, oh, it can be a metabolic epilepsy. Um, and then if you go back to your molybdenum cofactor deficiency slides, you mentioned urine dipstick
Yes.
for urine sulfites. There are no validated urine dipsticks for sulfite
Oh, okay.
testing. Um, the only ones you can get are off of Amazon that are actually for wine testing, and Dr. Dietzen would be very upset if we actually used those here because they can affect the laboratory's cap and class certification.
Oh, wow.
Um,
Interesting.
what what you can actually do is send urine sulfocysteine to Mayo, call them to make sure that it's run stat, and you can have an answer in about 3 days. Molybdenum cofactor deficiency, when presenting in that early infantile period, it can have a lot of overlap with HIE presentations, including in neuroimaging. And the treatment, Nulibry, is recommended to be started within a few days of symptom onset. So that's actually the fastest method of diagnosis that you can do. I would argue that test should be sent for anybody that presents with HIE symptoms or neonatal seizures, that doesn't quite have an obvious reason to have those. Because that's actually faster than even doing a rapid exome or genome.
Thank you. That's really helpful. I appreciate that. All right. Well, thanks everybody. I can give you a little bit more time of your morning back.